Good morning, everyone. My name is Carmen Maccagnano. I'm a urologist and I work at the Department of Surgery and Section of Urology in Sant'Anna Hospital at Como Lake, Italy. And I collaborate with Dr. Rodolfo Urle, who works at the Department of Urology at Humanitas Research Hospital in Milan, Italy. We would like to thank the scientific committees for giving us the possibility or discuss our ideas about active surveillance for recurrent low-grade non-muscle-invasive bladder cancer and outbreak. Bladder cancer represents one of the most expensive malignancies to treat and follow up due to its high recurrence and cancer-specific mortality rate inferior to 1%. Up to 70% of newly diagnosed cases of bladder cancer are low-grade, and progression in 5 years for PTAG1G2 is inferior to 1%. Transurethral resection of bladder tumor represents the standard treatment modality for non-muscle invasive bladder cancer, but we have to consider also the patient's comorbidities and anesthesia-related complications, especially in elderly patients, the potential complications related to the operation itself, and the cost of hospital stay and patient management. Active surveillance and watchful waiting are accepted policies in several low-risk conditions in urologic oncology, such as prostate cancer, renal cancer, and non-seminomatous germ cell tumors. What's the rationale of active surveillance and non-muscle invasive bladder cancer? Experienced clinicians are able to identify lesions with a low-grade TA appearance during cystoscopy with a high degree of accuracy of the pathological exam, especially in case of milder tumors. Active surveillance allows a reduction of the number of transural detection of bladder tumor throughout the patient's lifetime without compromising the possibility of intervention in case of progression. Active surveillance was suggested for the first time in 2003 by Soloway and colleagues, who described it as a safe and valid alternative strategy to transurethral resection of bladder tumor for low-grade TA bladder cancer due to minimal risk of progression and cancer-specific survival. Thus, different groups, including Humanitas University and Research Hospital, reported their experience in poster and presentation at American Urological Association and European Association of Urology annual congresses. The table summarized the results of the papers published until 2019 from 5 European and 2 American groups. As you can see, only Hernandez reported for progression to muscle-invasive bladder cancer. In the other series, the progression of a gradient stage was reported in a range of about 10-20%, so very low. In 2016, Humanitas Group published the results of patients with low-risk non-muscle invasive bladder cancer included in a local national observational program called Bladder Cancer Italian Active Surveillance Bias after diagnosis of recurrence. And in 2018, the same authors demonstrated that the progression rate was about 13% and 7% about gradient stage respectively. Thus, we suggest that non-muscle invasive bladder cancer recurrence with low-grade appearance after initial pathological diagnosis of low-grade TA tumor should be managed appropriately using an AS protocol. Moreover, the same group have recently demonstrated that a proportion of patients under active surveillance operated with transurethral resection of bladder tumor because of typical neoplastic appearance showed pathological data which are significantly different from the initial impression, even if given by an expert urologist. As a matter of fact, approximately 30% of patients deemed to have active surveillance failure because they didn't harbor any neoplastic lesion at the final pathological specimen. These data, although surprising, seem to strengthen the role of active surveillance in a selected population with recurrent non-muscle invasive bladder cancer. Moreover, AUA and EAU recently reported about active surveillance and bladder cancer in the guidelines, particularly the AUA guidelines in 2016 suggested that surveillance of a patient for whom the risk of fulguration may outweigh the risk of disease progression, and in 2019 update, EAU suggests active surveillance in selected cases based on the recent papers that I showed before in the previous slides. What about active surveillance and outbreak? Before COVID-19 outbreak, over 200 patients were on active surveillance at Humanitas Research Hospital, and 7 cystoscopies per week were performed in an outpatient setting. However, the pandemic has led to a rapid change of management on non-muscle-invasive bladder cancer patients, leading to a change of recommendation of scientific societies, as you can see, for example, at the website of Italian Society of Urology or the website of EAU. In this scenario, we can propose 2 possible amendments of active surveillance and bladder cancer strictly applicable during this pandemic. First, increasing the maximum number of lesions from 5 to 7, which leads to transurethral resection of bladder tumor, and second, extension of the follow-up period during active surveillance from 3 to 6 months. Curiously, we could take advantage from this virus, increasing the number of patients in the active surveillance protocols due to the restricted access both to the hospital and diagnostic procedure in general. And we discuss our ideas in editorial which was recently published in the Arab Journal of Urology. We would like to thank you for your attention, and please don't hesitate to contact us at email that you can see on the screen. Thank you.